We got a temporary glitch, guys.
Hello, I'm Cory Burnell, and this is The Doctor is In with Dr. Randy Smart, and I have the privilege of joining him on this episode for discussions about health and well-being, and he brings something to you every episode that I'm sure you find valuable. So thank you again, Dr. Smart, for doing this show.
It's great to be here, Cory. Thank you.
Well, excellent, and I guess we're going to be talking about the topic of fall prevention, right? How somebody ought to avoid hurting themselves and falling, and I imagine the consequences of it as well. Huh?
Exactly. Why that's important, what the magnitude of it is. Why is it that is such a big deal?
Mm.
And then what can we do to prevent that?
Yeah.
So there's quite a bit to talk about today. I can tell you the magnitude of this problem is really what people describe as an epidemic. And some numbers, something like 3 million people will go to an emergency room each year because they fell and got hurt.
That's incredible.
3 million.
Wow.
Of those, almost 1 million will be hospitalized. Just short of 1 million would be so 1 in 3. And then of those, 32,000 will actually die. So that is more deaths. In an average flu year, this probably isn't a great year to talk about flu, but
Sure.
in an average flu year, we lose about 30,000 patients. But we actually lose 32,000 to falling, and it is the most common injury and common cause of hospitalization in our senior population.
So I imagine in your practice, as you look for topics to bring to us as a community and share with us, how often do you see a fall victim, a patient come see you? Because is this daily? Is it weekly?
It is almost every day,
Almost
Cory.
every day.
Almost every day. And I was telling one of the studio staff just a moment ago, if on a day like today where I'm working and I get one call where somebody has cancer, not a good thing. If I get another call where somebody fell and broke their hip, that's the one I worry about. That's the one that's in trouble. The one with cancer, we can probably help. We can probably do a lot about. We could maybe even cure. But with the one with the broken hip, it is the bigger problem. In fact, if you had twins and one twin had a heart attack and at the same time the other twin fell and broke their hip, a year later the heart attack is more likely to be alive.
Wow. Yeah, that segues right into the question of how serious are these types of injuries, and when you're talking about death, at 32,000 deaths a year due to falling, I would normally think somebody falling and hitting their head, but you're talking about a hip injury could be lethal.
Or less. So think about it this way. Let's say you're 30, 40 years older than you are right now, and your hair's a little grayer. So what we know about you is your vision would not be as good, hearing probably not as good, maybe muscle mass not as good. And as a result of those things, your balance is not as good. And balance is very complex stuff. But because of that, vision, hearing, balance, there's something on the floor, something that runs by, something in the parking lot, and you're much more likely to trip. Okay, problem number one, you're more likely to trip. Number two, if you and I were to start falling, we'd react. We'd catch ourselves, right? Hands out. Well, 30 to 40 years from now, your reflexes are not going to be the same.
Right.
So problem one is you're starting to fall. Problem two is you don't have the reflexes, so you're not going to stop falling. And problem three is whatever you do hit, those bones are weaker and more likely to break. So it's what I refer to as the perfect storm. Poor balance, poor reflexes, weak bones, boom, now you've got a broken bone. And the problem isn't the broken bone. The problem is the consequences of breaking that bone. And this is where I think as a medical community we could do a little bit better, because when somebody breaks a bone, we feel our job is to mend the bone, to cast it or operate on it, put it back together. We've done a great job. You can go back out there, but wait a minute, they fell. Why did they fall? Why did they have weak bones? Why did they break a bone? And that's where we could improve a little bit. So it's kind of this perfect storm.
Yeah, well, it makes me think of kind of like follow-up treatment or care, where with many things somebody leaves the physician's office and where they're given a sheet of care they're supposed to do for themselves afterward, right? Now here in the case of a fall victim, is anything delivered like that in regard to maybe things they ought to think about around their home or what caused the fall or ways in which they would prevent something like this in the future?
Exactly. So perfect question. There's a lot of variation in practice. So if you go to the emergency room, and I'm not specifically talking about Calaveras, I mean across the country, and you fell, the first question is, did you get injured? So they take the x-rays, and let's say there's no fracture, no injury. They say, good news, Cory, you didn't break anything, you can head on home. But there isn't the, wow, why did he fall? How do we prevent that in the future? What kind of information we can give him? We don't, there's a lot of healthcare venues that just don't do that. Now, in my practice, I've been doing that for years, and a number of practices, and there's good practices in Calaveras County that would happen. But across the country, and even in this county, really, we fall short of doing the things we need to do. We just don't do that. And it becomes really challenging. I mean, what can you do? How do you convey that information? How do you follow up on it? It becomes challenging, but we really believe these falls are preventable and we believe the injuries are preventable, and we know there's things patients can do, doctors can do, and the community can do, and we need to get that message out to our patients and our seniors.
Yeah. Well, now if somebody wanted some action items or takeaways from in that case, okay, well, what should I do, doctor, that I ought to be doing in order to prevent falls? I would think there's probably kind of a standard list, you might say, or obviously some common sense items. Not having things in the way of their walkway, right?
Exactly.
Right.
Yeah, exactly.
So, but let's go down a little bit of a suggestion list you would have for a patient.
Yeah. So first of all, there has to be an awareness. You have to realize, I'm 75 and I'm at risk.
Mm-hmm.
Actually, I'm over 65, and actually I am over 65. So anybody over 65 in general is at risk. So there has to be that awareness. And then if you are over 65, you just need to slow down a little bit. You don't have to hurry, you don't have to get hurt, you just need to slow down a little bit. There are things you can do in the house, probably with the help of your family. For example, you can unclutter the house. A lot of us, we accumulate things as we age, and you got stuff everywhere, and pretty soon there's a cat, and then there's a box, and then there's newspapers, and so to really unclutter that environment is really important. Lighting is really important, and this is one people don't realize, but the kind of lighting we have in the studio today is closer to what should be in these homes, and they just don't have it. So you need, these are folks that don't see as well, so lighting needs to be good. Grab bars, particularly in bathroom environments, grab bars are a really good idea if they're installed properly. They're probably avoiding the stairs, trying to find ways to continue living in your home with less stairs or safer stairs. If you use the stairs, you should have rails on both sides, not just one side. And you should go slow. You should kind of go slow. So there are many things like that, and there is a list, as you say, that you can follow. There's things you can do personally. You can make sure your vision is corrected and good. Glasses, eye appointments, maybe having cataracts fixed, corrected. Having good quality shoes, so you have good support, feet on the ground. You can imagine if you have a high heel, you're probably more at risk for falling. And speaking of high heels, women are more at risk, not because of high heels, but just in general, they're more at risk. People that live in rural environments are more at risk, that's proven. So if you live in a Calaveras environment, you're more likely to fall than if you live in a city.
Sure.
Not exactly sure why. It'd be pretty easy to speculate. But personally, you can shoes, vision, and then a lot of times I will advise my patients to use a cane, and I'm not advising them to use it to take the weight off a joint, a sore knee or a sore hip. I'm advising them to use the cane to improve their balance. So if you have 2 feet on the ground, that's pretty good. If you have a third point on the ground, then your brain really is stable, your body's stable, and if you start to fall, easier to catch yourself. So having a stick or a cane, in spite of the stigma, it's really hard to talk people into this, can be a really useful thing.
Yeah, that's interesting. Well, I think of the leverage that you have on your upper body with a cane because you're connected up here, whereas, if you trip with your feet,
what do you got?
Right, nothing to stop you until
but if
you
you've
get
got that extra point,
yeah.
and maybe upper body strength is a little better in most people, hard to say. One of the things that is particularly useful is working on balance exercises and strength exercises, and there's lots of opportunities to do that. You can do it on your own. You can do it with a physical therapist. You can do it in organized classes. And our organization, the healthcare district, sponsors organized classes for that reason. But there's very good evidence that if you do just a little bit of balance training and easy strengthening, that your fall risk drops significantly. Now, I'm not talking about jumping jacks or push-ups or marathons, because that's not what our seniors need to do. I'm talking about things like even sitting in a chair, doing motion exercises, maybe with instruction, maybe standing, sitting without using your arms. There's a number of things you can do to improve that strength. And when you do that, you don't fall as much.
Right. Yeah, there's a couple things on that list. Just wouldn't have occurred to me. For example, improving your vision, whether it be surgery on your eyes or glasses, improving the lighting in a room, that wouldn't have occurred to me. And of course, then this notion of, if you're more susceptible or at risk of falling due to poor balance as we age or getting weaker, well, then something that strengthens yourself, those types of exercises that would help you. This all makes very good sense.
And they shouldn't be intimidating. When people talk about exercise and you're 75, 80 years old, you go, well, but these, if you were to go online and look at some of these classes and events, these are things like Tai Chi, and Tai Chi is excellent for this kind of thing. And these are slow movements to improve strength, improve mobility, improve reflexes, and you can be 98 to 100 years old and do these. And you do them in chairs. If you're a little more fit than that, and some of the students are, then you can do them standing. But they can be really beneficial.
Yeah. Well, we've covered some very good ideas here on avoiding falling and improving, the avoidance of falling, lowering that risk. Now, why would a broken bone, like a hip or an arm or a leg, for example, be such a catastrophic event that it could possibly be lethal for an elderly person?
I was so hoping you would ask this question. Yeah. So if you fall and break your arm, that shouldn't kill you, right? Or your leg. That shouldn't kill you, but here's what happens. Let's use the, either one. The most common fractures we see are either hips, wrists, where you try to catch yourself, sometimes clavicles, same mechanism, and often we see pelvic fractures. So you have a pelvic girdle, the wing bones so those are the fractures that are the most common. So this is what happens. You fall and you break one of those bones. The medical team and the ER jump on it, ambulance, whatever, and we fix those bones and say, Mr. Smith, we've fixed it. What a great success. However, you can't go home today. You can't go home from the hospital today. We need to make sure you're able to ambulate well, and so that patient ends up laying in bed or maybe going to a rehab facility. And we know that they don't have the reserves because that's kind of contributing to why they're falling and why they're not as strong as they used to be. So they don't have the reserves you may have or a younger person may have. And so they become a risk for bed sores, and those can develop in 24 hours. It's an open skin area. Maybe you need antibiotics. Maybe you get a blood clot, and the blood clot causes your leg to swell, or maybe goes to your lungs, and so then you need more medication. But maybe in those 2 or 3 days, you're just not sleeping well, you're in the hospital. That's not normally where you go, or the rehab facility. So why don't we give you a sleeping pill just to help you sleep? We're nice people, we want you to sleep. And by the way, the skin thing looks pretty bad. Maybe an antibiotic. Let's put you on an antibiotic. So by the time you get home, you're not the same. And you part of it is medications. Part of it is your ability to recover. So within a short period of time, you may develop pneumonia because maybe you're taking pain medications and you can't clear your airway or cough as well, and you're laying around. So maybe you get pneumonia, maybe the blood clot gets worse, maybe the skin infection gets worse, and you just watch this like dominoes, and you know it's happening, and you can't do anything about it. I mean, not really. And so within a year, the patient is gone.
Wow.
They're gone. I mean, ultimately, it's not that broken bone. It's really not the hospital. I kind of implied that it was, but it's all the things that happen as a result of that broken bone.
Right.
Maybe when you go home, you have a little bit of diarrhea from one of the medications or a new diet, and so you have to get up at night to go to the bathroom. You've got a broken bone. So then you fall, maybe you break another bone. Or maybe you just lay on the floor for a day or two. I mean, and it just crescendos into a bad scene.
Right.
Bad situation.
Yeah, you were talking about a population that generally is more at risk of medical complications, and you put yourself in a situation to have medical complications with that fall. Makes perfect sense that there will be additional ancillary consequences.
Yeah, one of the things that's really challenging for us is really conveying that information to the family. And I've been through this so many times where grandma falls, breaks something. And so we get her to the hospital, we fix the bone, we put a cast on, and we sit down with the family and say, we're really worried. And they say, no, got the cast, everything's good, we're taking Granny home. And then you get a call a couple days later, well, she's not eating very well. And you say, look, this is a big deal. This is a potentially fatal event. And they go, well, we'll give her more applesauce. And then a couple days go by and they call and they say, we think she's constipated. We know they gave her some pain medicine in the hospital. We think she's constipated. So she's spending a lot of time in the bathroom. And you say, look, this is a major thing. Granny's not going to do well. And the family has a hard time coming to terms with that. They don't know that. They don't see it. But I can tell you in this county, there's some very well-known families that I've been through this scenario with, and I've said, look, we've got a big problem here. And sure enough, it didn't go well. And it's not that the families don't care, it's just hard to understand how those series of events occur.
Yeah.
Families can do more. They can definitely make the house safer.
Right.
They can definitely work on lighting. They can definitely work on physical therapy. They can even work on home exercises like standing, sitting, standing, sitting. But these, most families are working people or have children, or, it's not like they're sitting around waiting to run a rehab facility.
Yeah. Now, are there medicines that are fairly common that people in their 70s or 80s may be on that could have a side effect, like causing dizziness or maybe the inability to move their feet as quickly? And if there are, perhaps these are some things they ought to be looking at if they're on a certain medication, whether it could cause an increased likelihood of falling. Is that something they should be concerned about?
Absolutely.
Okay.
Absolutely. In fact, I'll give you an anecdote. I have a good friend who is also an internist, and his mother is 101. And she has been falling a lot lately, and he's really worried. And she's on a number of these medications because she has a number of medical problems. And so finally they said, let's stop everything. And I'm not recommending anybody do this without medical supervision.
Sure.
But they stopped all her meds, and she hasn't fallen since.
Interesting.
And I think that really makes the point that even though we're trying to do the right thing and we are writing prescriptions, Sometimes we're creating problems that we may not just be aware of. In an effort to help, these may be the unintended consequences of having a prescription pad and a pen. So the medicines I get concerned about the most are the pain medicines.
Okay.
Yeah, so particularly the narcotic pain medicines. And this is another perfect storm, because if you take narcotic pain medicines, morphine would be an example, Norco is an example. When you take those medicines, one is you're just not alert. You're not as alert, unless maybe you've been taking them for a long time. But if you're 75, 80 years old and you're not normally taking them, then you're not as alert. You're not as in tune with your environment, so your risk goes up. And then they notoriously cause constipation, which creates an entire medical problem that I think puts them at a higher risk for falling, because by the time you treat the constipation, then they have the diarrhea, then they're running back and forth, and they're frustrated, or just sitting on the toilet a long time. Sit on the toilet a long time, your back hurts. So the pain medications I really get concerned about, and I really try to get these patients on something that is not a narcotic.
Okay.
But the sleep medicines, I think, are in some ways just as bad. Sleep medicines make you drowsy. These patients tend to get up at night. Often they have to use the bathroom or something. There's a noise outside. Older people just get up more at night. And so if you're taking a sleep medicine, you just may not be as agile or as competent and careful as you normally would be. So it's a big interest with the medical community. How many of these medicines do these patients really need? And when can you stop them? And is that safe? And I think you hit on it exactly. We really need to look at that.
Well, when people are taking medicines, of course, they look at a pros and cons, and this is the benefit, but we could have some side effects. And I've never been told, hey, maybe a side effect might be an increased risk of falling, and maybe in whatever circumstance a patient is in, maybe that's some side effect they ought to concern themselves with. And it's
right.
Just a more informed patient if they've had a discussion about how this might impact their risk of a fall, a serious fall.
And is it a patient that understands what you're saying? And you know, kind of conventional medicine is if you have a problem, we pull out the prescription pad and say, here.
Sure.
We really need to get away from that. But it's driven by some really powerful forces in this country and the world. And we need to put the prescription pad down and really rethink how safe that is.
Right.
And for example, in my friend's case, his mother is 101 years old. Do you really need to lower her cholesterol? Probably not. You know, I mean, she made it, right? She's 101. There's nothing to prevent.
Right.
Right? And so we need to be a little more thoughtful about what we do with that powerful prescription pad.
Yeah.
Absolutely.
Almost like a quality of life consideration. I mean, how's this going to impact the quality of life? Maybe it's extending life a little bit, but is it a quality? Is she going to be hurt by a fall or drowsy? It was interesting that you said there may be choices amongst pain medications that maybe a patient ought to discuss with their doctor about those implications. Like, well, what could increase my risk of a serious fall versus another medicine that perhaps might not?
Or maybe the conversation ought to be, we can make that pain go away, but there are problems with using these medications. How much pain can you tolerate?
There you go.
Given the risk. And I've had this discussion many times where people say, you know, if you tell me I have to live with this a little bit and I have to tough it out, I can do that. And we don't have those conversations nearly as much as we should. Again, pull out the prescription pad, say, here, 10 minutes, you do it again, 10 minutes, you do it again. So, and I'm not belittling or criticizing my colleagues. I mean, this is very hard work.
Sure.
And they mean well, but I think we should have that discussion with patients. I know you're in pain. There are some safe things I can do to help you, but it's not going to completely eliminate it. Can you live with some of this?
Interesting.
And 9 times out of 10, I think they'll say, you know, I can live with it. They really trust us.
Yeah.
You know, they really do. And that's one of the beautiful parts about medicine is when we have these appointments, they really turn to you and say, Doc, you tell me and I'll do it. The trust is still there, and that makes it a lot of fun.
You know, that is a great thought to end our show on. We've come to the end of it already, but you're right. You know, trust your physician. You have a trusted physician. Have these conversations with them. So, Dr. Smart, thank you again for putting this show on, and thank you to our viewers for joining us. We hope to see you next time on The Doctor Is In with Dr. Randy Smart.